Howdy, everybody. So glad to have you with us to kick off our fall season of Bridging the Divide. I know many of you have been here before, but for those of you who haven't and aren't familiar with Roots and Roads, I'd just like to share a little bit about us. Our vision is to transform the end-of-life experience into the final act of living well. And we go about that in a few different ways, one of which is exactly what we're doing tonight, coming together to learn about end-of-life issues. And we're really excited to have Tani Bhatti with us tonight and next month as well. This is kind of a two-part series. Another way in which we try to transform the end of life is by financially assisting hospice patients of limited means for basic needs that aren't covered by health insurance. And then we also have our newest resource, which is an online resource called the Crosswalk. And that we launched, at the very end of last year. And we've just been kind of refining it throughout these past several months. But really, it was built with the idea of bringing together resources, starting with diagnosis of serious illness, all the way through end of life, through to final arrangements and bereavement, to everything in between. And so if you haven't had a chance to visit that site yet, we would love for you to look through it and give us your feedback. Any resources maybe that you know of that have been very helpful that we might add. We really would cherish your opinions and also any additional knowledge that's missing. With that, oh yes, of course, like to thank our sponsors. Our overall sponsor this year has been the Connie Hillman Family Foundation. We've also been able to bring this series free of charge to folks with the great support of Pima Council on Aging, Right at Home, and Casa de la Luz Hospice. And I'd just like to give a quick shout out to individuals who donated to underwrite tonight's session. So there are so many of you. We're so grateful for you being here and for your belief in what we're doing. So thank you. With that, I will turn it over to our colleague, David Fife.
Evening, everybody. Thanks so much, Julie. It's wonderful to be able to partner with so many different organizations throughout the community to draw on this expertise and to further the conversation. And one of our outstanding partners who's underwriting tonight's session with Tani Bhatti is Casa de la Luz Hospice. And so we're so grateful for their partnership and their support, and we look forward to moving forward together with them next year and in the years to come to bring more of these education sessions to our whole community. So thanks to Casa. And now, why don't we get started? We are so delighted to have Tani Bhatti with us. She has been a nurse for over 47 years. You can see her bio in front of you. I'm not going to read that for you. But I do want to say that I've had the privilege of working and presenting with Tani through the years, and she is a true gift to this community. She has the courage to sit with our most difficult questions and fears and say together that we will find a path forward, that we will learn the resources and skills and find the tools we need to address our questions and concerns. And it's not often that we find folks who have dedicated so long in their lives to helping people enter into these conversations and to offer the community these perspectives and insights and wisdom that she's gained throughout her years. So we're so excited to have Tani here. And thank you, Tani. We're going to turn things over to you now.
Okay, thank you. So I'll do screen share. I'm going to share. All right.
Yep.
So thank you for the invitation. Thank you for the work that you are doing in Roots and Roads to educate the community, because this is one of my passions. So I appreciate any efforts out there. Thank you for the kind words, David. And I just want to be very clear that if you think, does not want to advance. Let's see. There we go. That if you think I'm any kind of expert on this, I am not. I see myself as the perpetual student because my patients and my families have been my best teachers. And as a student, I've also been the dunce several times. But that's the human part of it. We're all going to make missteps. This is a very difficult area, especially to work in. And especially with the topic of end of life, we're dealing with fear and denial. That's particularly touchy subject. So give yourself some passes if you make an error, like I have made many and will be sharing. Because here's the issue. Here's the joke. Death is hailing a taxi and he goes, cripes, there goes another one. What am I, invisible? That's how too many people look at end of life. They put on the blinders and they think, okay, if I don't make eye contact with death, it's not going to happen. If I don't finish my paperwork, my advanced directives is not going to happen because certainly God won't take me if my paperwork isn't done, right? So we have a lot of reasons that we like to avoid that conversation. And very often it's just because we are scared. So what we need to talk about and what my work is how do you gently remove those blinders to take away some of the fear and empower people with end-of-life decision-making? Because we're all going to die. So we're all going to be visited by the angel of death. I've kind of renamed him or her agent of change because I figure there's nothing like facing your mortality to make you look at and change your life, right? And it's in those changes and how we respond that makes this whole journey very interesting and very often unpredictable. So my intention tonight is to kind of give you a bigger view of the possibilities, of the issues, of some of the barriers out there, maybe how to overcome some of them. So whether it's within your work or whether with your family, that you have a little bit more tools to work with, or at least understanding or compassion. So it kind of starts with self-awareness, and we're going to do a little poll right now. So I want to ask you very quickly, have you ever experienced what you consider a good death? Yes or no? And have you ever experienced what you consider a bad death? Yes or no? Now, while we're getting some tallies, you might say, why are you even asking this? And it's because what our experiences are as human beings, we carry with us in our work especially. So if you're somebody who's had an experience of a bad death, you're more likely to be fearful and as you're working with folks, and that fear may translate to them. Whereas if you experience a good death, you may be able to translate that sense of peace too. So let's look at the tally so far. So most folks have experienced a good death, which is awesome, 79% at the moment. Bad death, 61% said yes. Well, 59. Others said no. So that's really, it's just interesting to know what are people's experiences out there. And for you to be aware that not everybody's on board. If you've had good deaths and people have had bad deaths, you need to start asking about what their experiences are. Okay, I guess let me do a share results there. Okay, do I hit stop sharing? Okay, I'm going to try and advance. And okay, click out of the poll so I can advance.
It's off.
Okay, it's not letting my screen advance right now. There we go. So ask yourselves how your experience has affected what you believe about dying, because again, you're going to carry that with you personally and professionally. Keeps out getting that little knocking thing. It doesn't want me to advance. There we go. So basically, when you're dealing with an end-stage illness, it's quite a roller coaster that you're on. The family's on it, the patient's on it, the care providers are on it. Everybody's on it with the twists and turns, and it gets pretty scary. But this is the most important place to start. As long as we can advocate, support, and educate people from the beginning, we're going to make that journey a lot easier for them. Now, the biggest need that people have, which is still the biggest deficit that is identified out there, is the lack of communication. Probably no surprise for those of us in the field. Doesn't like to advance. Why doesn't it like to advance? Come on. Communication with the dead is only a little more difficult than communication with some of the living, right? You probably had people like that, professional and personal life. It's not easy because we're all a little bit different. So, but the consequences of not communicating, especially with the end of life, can be absolutely devastating, psychosocially, physically, emotionally, spiritually, and financially to the patient and the family alike. So let me give you an example of those, of who pays the price of poor communication. Let's start with the patient. There was a woman and her husband I worked with, and he had had lung cancer for a number of years and had been in and out of treatment, but now had recurred again. And they went back to the doctor and he said, well, you know, you can try this treatment. And so they were dutiful patients. And they said, okay, we'll try it. But then the wife researched the drug. And what she found out is that there is a 0.2% chance of responding. Now, responding is not remission. It's certainly not cure. Scientifically, response is anything over 2 weeks. And she said, what am I going to do? He's going to die anyway. The treatment costs $54,000. We are living on a fixed income. I will be totally financially devastated, but what kind of wife would I be to say, don't do it, dear? And then I talked to the husband separately, and he said, I am so sick of treatment. I don't want any more. I don't need any more. But my poor wife, she'd think I was abandoning her if I didn't go for it. So we had to get the patient and the spouse communicating, and then the two of them communicating with the physician to say, what are our circumstances? What are our goals? What's realistic here? Family. I knew of a 14-year-old girl who had cancer. She lived in Mexico and she had failed traditional treatment. So they wanted to put her on an experimental drug up here, but it had to be given every 3 weeks and it was fairly costly. They didn't have money for it and insurance didn't cover it. So the family would go back to Mexico and sell off things, borrow money from churches and family members, et cetera, and come back about every 4 to 5 weeks with the money for some treatment. Unfortunately, they didn't understand that this treatment did not offer a remission. It only offered information to see if it would make a response or not. So they sold the last of their furniture and their only vehicle 1 week before she died. So they were devastated on all levels because of poor communication. Healthcare providers. Boy, I don't know about you, but it hurts my heart when I see people suffering needlessly or to have said, if I had known, they didn't know. And there are no do-overs with that. And then the insurance providers pay a price. Now, because we're probably not particularly empathetic toward the insurance provider, but what's true is if they start spending more and more money toward end-of-life care, and especially futile care, all of our rates go up. So it's a no-win for everybody. And by the way, still today, healthcare costs are the #1 cause of bankruptcy in the US, even for people with insurance. There we go. Okay, so let's talk about some of the barriers that coming up. Fragmentation is one of them. Now, if you've ever been a patient in a hospital, you're pretty familiar with this because you have the doctor for your heart, the doctor for your lung, the doctor for your kidneys, the doctor for infectious disease, and they're all reporting on a body part. So when they go to the family and the kidney doctor says, hey, the kidney functions are stable today, what does that mean? How does the family interpret that? They think, oh, well, then my loved one is stable. Oh, maybe they're getting better, when in fact, that's not the piece at all. So it's making sure that there's one physician, usually the hospital, is to oversee everybody to say, let me give you the full picture of what's happening so that you have a sense and can make decisions accordingly. Another issue is language. Now, I'm guilty of this. I've been a nurse for so long. I use terms that I don't recognize that people don't know. They're too familiar for me. And I will use them when I'm talking to patients and they have no clue, but you know what? They're not going to tell me they didn't understand. So I'm giving them information about their treatment, about their health, et cetera. And they're nodding their heads. Yep, yep, yep. I ask if there's any questions. Nope, 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 no questions. And I walk away going, oh, great. I did a great job. I taught them. They're comfortable. I had no idea they had no clue what I was talking about because they were too afraid to ask me, or too embarrassed to ask me, or didn't want to look stupid. So I have to think about this in the way of I look at high technology. I don't do tech very well. So when my sons come up to me with the latest gadget and they want to show me all these apps, I am totally threatened by it. So I'm going to listen carefully, but not too much. I'm certainly not going to ask any questions because I don't want more information as something that threatens me. And I don't want them to know I'm really stupid with that. So language is a barrier, and we have to make sure that we've stopped and said, you know what, I've given you a lot of information. Can you let me know what you heard me say? I want to see if I've done a good job or not. But very often, and certainly I'm guilty, I have not taken the time to do that. So this came from a medical journal. It says medical studies indicate most people suffer 68% hearing loss when naked. Okay, really true. I mean, for adult learners, if you are feeling really good tonight and you're well fed and you're not tired and you had a great day, you are lucky to remember 60 to 7% of anything I had to say. If you're a little bit stressed, you're ready to go to bed, it goes down to 30 to 40%. So you can imagine that if you're suddenly confronted with difficult news about somebody's health or impending dying, the ability to hear goes out the window. It's not that you're in denial, it's that you're human. So you can't hear all of that. So we have to remember that they may need that information given to them time and time again so that they have something that they can remember. I mean, I worked with a nurse who actually worked in hospice, who was also a chaplain, and her husband was a physician. So these are people who know, right? And she sat down and told me, she said, you know, when the doctor came in and told me I had stage 4 breast cancer, after that moment, I heard nothing. Now, I know she was sitting there telling me about the treatments and what were going to happen, but not only could I not hear her, I didn't have the ability to say, stop, come back later. I need time to absorb this. So we really need to appreciate the fact that people may need to hear it again. Again, it's not denial, it's not cherry picking. They're human beings absorbing some very difficult information. Okay, so this is eye-opening for me. 40 to 80% of information received orally is forgotten immediately, and over half is incorrect. Now, I don't know about you, but most of my nursing career, I've given verbal information. When I go to the doctor's office, he or she gives me verbal information. So to understand that this is not the way to go is really critically important, but it's easy to overcome. All you have to do, go back. For the family, have them, if it's going to be an important conversation, tape record the conversation. That way they can play it back again and again for themselves or for other people who want to know, or bring a list of questions and take notes. For the provider, please write out diagnoses and goals and next steps. Consider a follow-up appointment just to review again and field any questions once they've had time to absorb it. And again, verify the understanding with the teach back, meaning help me, please tell me what you heard me say. I want to make sure I did a good job with that. Okay, more barriers. Yep, we got a lot of them. Lack of training and comfort for healthcare providers. Now, I don't know about who's in the audience, but I know that when I went through nursing school, I had a paragraph on end-of-life care in my junior year. That was it. So if you're not comfortable with it, you haven't trained in it, it's going to be really difficult to raise those conversations. Fear of failure and fear of death. Guess which profession has the highest fear? Physicians. Want to guess which specialty? Oncologists. Now, be clear, this does not make them bad people at all, because if you go to the cancer doctor, you want them to raise the sword and say, I'm going to fight this for you. But if there's a point at which that cancer comes back and cannot be treated, lowering the sword and raising the white flag may feel like failure. And if the physician is having difficulty with feelings of failure, he or she may be more likely to treat inappropriately for a longer period of time. Along with that is really attachment. The longer a physician knows you, the harder it is for him or her to identify the point at which kind of you're cresting with your health. So that's why it's actually a really good idea to get a second opinion. but also realize, and this is again where our compassion needs to come in for the people that we work with. When I was working in hospice, there was an oncologist out there who had quite the reputation that they said that even when people in rigor mortis, he was giving them chemotherapy, right? One of those. So he did not like hospice at all. And so if he found you doing a hospice referral, he chewed you up, right? So good enough, I got a referral on one of his patients from one of the other attending physicians. And I felt him coming up behind me and I just got rigid. I thought, okay, get ready to get a chewing. And he said, "You're from hospice?" I said, "Yes." And then I took a different route. I said, "I can't imagine how difficult it must be for you to follow a patient and know them for so long and then to have them not do well." And then there was silence. And then after a couple minutes, he told me a story about a patient that he had followed for 30 years, became friends with him. And he went through medical crises after medical crises throughout those 30 years. And each time the physician was able to pull him back. But this one time he went through a crisis, the physician was on vacation and the patient died. He never forgave himself for that. He thought there's something I missed, something I should have done. And that's why he kept treating and treating and treating patients, because he had a lot of unresolved grief. And after he told his story, he started to cry. I thought, wow, what a transformation. And then he gently said, "I'm glad you're here. Get him to hospice." So we really have to be compassionate with others. We don't know what their experiences are until we ask. And then one of the biggest issues we have is that of omission. We often do not give enough information on which a patient or family can make a decision. Now, a common one in the ICU might be, let's say I'm a daughter and my mother is 88 years old and she's got multi-system failure. She's dying, but I haven't been told that specifically. And the doctor comes up to me and says, "Well, if your mother's heart stops, do you want us to start it up again?" And it's about CPR. I'm like, whoa, why are you asking me? I'm not the doctor. And then two, I think, well, gosh, you certainly wouldn't offer it as an option if it wasn't reasonable. And therefore, what kind of daughter would I be to say, "Nah, let her go"? So I may quickly say, "Yeah, restart it again." The doctor may walk away going, "I can't believe it." They're in denial. But the fact is, you haven't been given enough information. What are the benefits and burdens? What are the options? What is her disease status? And let's talk about the reality of what CPR and resuscitation is for. The original intention of CPR is to treat sudden reversible cardiac arrest due to electrocution, drowning, problems during the surgery in otherwise healthy persons, period. That's important to know. It is not change the course of a progressive illness. If you have brain tumor or a liver failure before your heart stops, if that heart starts going again, you will still have a brain tumor and liver failure and die of that. So somehow over time, we've skewed it and made it a tool that everybody is using. So let's kind of dig into how we really even present this. So a CPR, or a full code in the hospital, it's not just the nice chest compressions that you see on TV. It's the intubation, it's the ventilation, it's the defibrillation, it's the drugs. It's a pretty messy kind of situation, right? And along with that there's risks: broken ribs, punctured lungs, aspiration, liver contusions, etc. So pretty serious stuff, right? But how do we present that to the patients and families? Now, my wonderful friend, Paige Hector, who was going to be presenting with me, shared this slide. This is the consent form for a family member getting cataract surgery. Side effects, rare side effects, all the complications, including death, et cetera, that the patient was required to read, review, and sign. Doesn't determining code status deserve the same risk, benefit, or review or in obtaining informed consent? So if anyone knows that they're doing informed consent now for a DNR status, I would love to hear it. But in the meantime, this is a big concern. So how did we get here? Well, and actually there was a survey in Britain that 95% of the respondents said they got information about CPR and TV, which is true here too. So on TV, CPR survival rates are 70%. And we've seen them, that they just have a little chest compression, they get up the next day, there's no deficits, they go home, all is good with the world. Let's talk about what's real. So for all hospital patients, only 15% survive the initial CPR. And 1/3 of them may be restarted, but do not live long enough to leave the hospital. For frail elders, less than 5% survive the initial CPR, but only 2% of those over 85 survive without significant brain damage. And in individuals with advanced chronic illness, it's less than 1%. So we have to ask ourselves, why are we offering this, or how are we offering it to people if we're talking about resuscitation status? So, we want to respond to do everything possible for my loved one. And that's fair. If my son was ill, I would say do everything possible for him. But for me, that means do everything possible that may be of benefit. For me, that does not mean do everything even if it results in hastening death or causing more suffering. So we have to be really clear when we say do everything possible, what does that mean? What does that look like? And for those of us in the healthcare field, we need to paint the picture. And that picture isn't very pretty, but that really informs the family as to, whoa, that's what it looks like. And then it's also how we frame the information about survival. So for example, if I say, your daughter has a 5% chance of responding to this treatment, you might think, okay, that's low, but it's 5%. But if I turned it around and I said, she has a 95% chance of dying this admission, that really changes the focus and really puts them in a position of more preparation at that point. So our language is incredibly important. So that's why we've changed in some areas. Do not resuscitate means we're withholding care, is what it sounds like to families, and that's why they don't like it. Do not resuscitate. So some hospitals have changed to A&D, which means allow natural death. That lands very differently, doesn't it? Allow natural death. It acknowledges that we're at the end of a life cycle and that there's more to do as far as comfort, but without aggressive intervention. So we really need to provide clarity. Now, I have always had a thing about you got to use the D word, the dying word, but I do need to do a caveat there because there are some traditions, cultures where saying the word dying and death is not acceptable because they don't believe in death. They believe it's a passing on. So if you know that that's their word, incorporate that. But if you don't, make sure you are very clear when you're dealing with somebody who's probably going to be dying imminently. Do not assume the family sees and understands what you do. And I know this happens a lot. We look at somebody in the bed and healthcare providers, man, we know they look awful and we know that they're dying. The family knows they look awful, but they haven't been told that they're dying. They're waiting for it to be announced. So they're thinking, well, they're not saying anything, so maybe this is what they look like for right now before they turn around and get better. So we can't make assumptions. We can't soft sell it. And we have to avoid saying it doesn't look good. The euphemism. You can say it doesn't look good, and therefore let's talk about what the options are for care. But just to say it doesn't look good and assume that they know the person is dying, that's not fair to the family. So if we can't say the word, how do we talk about it? If we can't talk about it, how do we accept it? And if we aren't warned it's coming, how do we prepare for it? So when we're offering treatment for advanced disease, we got to ask, who are we really palliating here? Are we ameliorating our own sense of helplessness by offering technology? So one of the questions we can ask is, are we doing for them or to them? for them or to them? It's a good question to ask if you've got somebody, let's say, in an intensive care unit. So here's the patient in intensive care, artificial heart, artificial blood, artificial lungs, etc. Holding up a sign that says, "Please let me die." And the physician says, "What? And play God?" On the bottom, it says, "Sweet cherry, it's not on our list of technology." Now, I'm not going to bash technology. We do amazing things now that we never used to when I was a young nurse. But there's a time at which we need to say, it's not appropriate. We've come to the natural end of life. And how do we determine when that is? It's the duty of a physician to prolong life. It is not his duty to prolong dying. Now, more hospitals are setting up palliative care units. You're also seeing them on an outpatient focus, which is great. They're bridging the gap for dealing with people with progressive illness to manage the symptoms and also hopefully start the conversations early, knowing that that disease is going to progress until death. Fabulous docs. And there's one that I know that she is incredible, absolutely incredible at her work. But she sat down with me one day and she said, I got to tell you, if I've got a patient who's crashing and they're dying, and the family is yelling and screaming and saying, you have to do something. She said, it'll take me an hour to sit down with them to process their guilt and their anger and their fear. But it takes me 5 minutes to write another order for another test, for another medication. So sometimes we just do that for their survival, to have the appearance that we're doing something when we're doing nothing. But you got to understand her role too, because how do you not respond to this level of anguish if this is in front of your face? So again, this is the very human part of it. This is difficult. There's no easy answers for everybody. And this is probably the biggest struggle that those of us who work in this field is. The role of the healer is to be present in the midst of profound powerlessness. You can't change what's happening. You can't reverse the dying process. You can't take away the pain of imminent loss of somebody. It's a very powerless feeling. To be present is phenomenal and very difficult for people because we're human. So, how do you anticipate that? Head them off at the pass with early effective communication. Now, one of the handouts I gave you is a serious illness conversation guide, and more physicians are being trained to start entering these conversations and document it over time as people are dealing with progressive illness. Now, so by the time you get to the point where somebody's starting to fail, then it's looking at what our language is, because we've already communicated a little bit. So rather than saying a little more negative, it's time to start pulling back. Feels like withdrawing care, which is not well received, is to say, I don't know why this doesn't like to matter. We will intensify comfort care. Comfort and dignity are our highest priorities. Rather than saying we should stop aggressive care and heroic measures, again, it sounds like pulling back. It says, let's stop treatments that are not providing any benefit. Very clear, very succinctly stated. And rather than saying there's nothing more we can do, which feels like abandonment, say we may not be able to cure him, but there's so much we can do to add quality of life and comfort to the time he has left. So rather than saying, do everything possible, it's really changing it to saying, do everything that is possible. And what is possible is the pain management, massages, playing music, having visitors come in 24 hours, getting them home, getting them with hospice, etc. Those are the things you really want to focus on once you've determined we're dealing with an end-of-life scenario. So what studies have shown is that the most important information families need for making decisions is prognosis. Now, what's also true is that we're lousy with prognosis. I mean, especially when we're dealing with months out, because we don't know. However, as a disease is progressing, or as they're going through a crisis or a very end stage, we certainly can at least frame it with basic information. Are we dealing with months, weeks, days, or hours? And the family needs to know that. If they're thinking they've got months to go and the physician says, we're dealing with a couple of days, it's like, whoa, that totally changes what kind of decisions they're going to be making. So again, if the physician isn't forthcoming with that, again, the family can ask, what are we talking about here as far as time? But what complicates this is truth-telling. Because sometimes people think, well, if I tell you the truth and how bad it is, you're giving up hope. But let's talk about then the role of hope. So let me ask you all this question. And this is a poll for you. If you magically found out that a person you love was going to die in 2 weeks, would you want to know? So go ahead and answer. Would you want to know if the person you love most is going to die? Okay, so right now, just a couple people said no. Most folks say absolutely. And there's no right or wrong answer to that. It's simply what your answer is. But what I've heard mostly is that people say, as bad as the information that is painful, at least it gives me a chance to prepare and to do some and figure out what I need to do for the rest of that time for closure, etc. So thank you for participating. We can talk more about those who said no early, maybe at the end. Okay. So, hope versus truth versus time to prepare. Do you want time to prepare? Okay, so the most painful words I would ever hear again and again and again as a hospice nurse were, if I had only known. If I had only known, I would do things differently. And that is so painful because there are no do-overs. So the more you can communicate and get clarity about your situation early on, the better off you're going to be and not have such complicated grief. Death is not failure. Failure is not preparing them for death or providing options. So let me tell you about Gabriella as an example. She was 34 years old. She had advanced breast cancer. She had a 9-year-old son. She was estranged from her abusive husband. He abused her and her son. She was not legally separated, however, and her main support was her mother. Now, Gabriella told her mother clearly that as long as the physician offered chemotherapy, that meant there was hope. And as long as there was hope, she absolutely said, we will not talk about dying. We won't talk about any of that because I don't want to jinx it, period. So one day that oncologist called the hospice office and he said, I'm admitting Gabriella today. I want you to go admit her to the hospice program tomorrow. And I said, well, I can go over right now and admit her. And he goes, no, I'm going to give her some chemotherapy first. Like, whoa. That just hurt my heart. So I went over just to kind of talk to the mother to find out what was going on. Gabriella was barely responsive because she was so ill and declining. The mother was so distraught because she wasn't allowed to talk about anything in preparation. And she knew her daughter was dying. So sure enough, Gabriella got the chemotherapy that night, went into a coma, transferred her to hospice the next day, and she died 2 days later without ever obtaining closure with her mother, without ever obtaining closure preparing her son, and without ever getting legal support so that her son would be protected from her abusive husband. So just because a provider may be uncomfortable with truth-telling, the impact it has on the patients and family can be devastating. So if you always want to know, always tell me the truth, then let them know ahead of time and it gives them permission to have that conversation with you. So there can be a standoff between patients and physicians. Sometimes when I talk to community groups, they say, I adore my doc and I know he or she will let me know at the point that I'm starting to crest that hill. But I've talked to physician groups and they say, well, when the patient and family are ready to hear it, they'll ask me. So that means there's a standoff. So it's your life, you got to ask. And so what we need to do is support people in asking their questions. It's not just their right, it's their responsibility. And what I've done is some of the handouts are lists of questions to go over with the physician, lists of questions to talk about with the family, because it's your answers to find. It's not mine, it's your answers. But we say that you have the right to autonomy in medical care, but autonomy requires the understanding of their choices. And we as a support, whether you're a provider or a family member, need to help make sure we've got that. To me, this is key, and that's why we're doing a whole separate session on this next month, but understanding disease progression and the dying process. Because there's a lot of fear around this, and when people understand what to expect and how to manage it, they make very different decisions very often. So that will be next month. So the other issue are comorbidities. That means you've got more than one disease going on that could potentially end your life. So you may have heart disease and kidney disease. You may have Alzheimer's and breast cancer. So this is the old Price is Right for those of you who are as old as me and remember that game. Is what's behind the door number 1 or 2 or 3? Is it any better? And very often I get my patients with cancer going, okay, I just don't want to die of cancer. That's all. I just don't want to die of cancer. Anything else? But now they live long enough to get Alzheimer's. So sometimes we're choosing how to die. I was admitting a gentleman to hospice one day, and he had cancer of the lower esophagus, and it was eating into his stomach, and it was causing a lot of bleeding. He was having blood transfusions about every 3 to 4 days to survive. He'd already had all the radiation and all the chemotherapy he could possibly have for that tumor, and it was still growing now. So they couldn't do anything more about that part, right? But it had also spread to his brain. And the doc said, oh, but we can treat the brain tumor. So we had to sit down with this gentleman and talk to him about what would it be like to die of brain metastasis? What would it be like to get treated for brain metastasis, but allow the other tumor to grow unchecked in your body? And what would it be like to die of anemia, to stop the blood transfusions? And he was so grateful to have it laid out, because for him, he said, oh my gosh, I can time this, it's more comfortable. He chose to stopping blood transfusions as soon as he had the opportunity to bring all his family in to say goodbye. So understanding the different ways that we may possibly end our life and what would be more comfortable, those are individual choices, but again, they need to be informed. Okay, so keys to the navigation of all of this. Identify the goal initially. Is it cure, is it remission, or is it comfort? And that may change over time. If somebody's looking for cure, they're more likely to go for more aggressive treatment because they're looking for cure. Maybe the same thing with a remission. But if you've identified that I'm going for comfort only, then you really need to look at any treatments that are offered to say, is that going to promote what my goal is? Is that going to help me or hinder me from reaching that goal of comfort? So we also need to explore in more detail than we ever do the benefit and burden to the patient. What's it going to cost physically? Energy, function, safety. I mean, do they have the energy? How is this treatment going to affect that energy and level? Will they be safe to even stay at home, for example? Especially if they live by themselves. Financially, is it covered by insurance, and to what degree? How much is it going to cost? You're going to have to go to the business office to find that one out. And what about the time? Is this treatment going to be once a month, once a week? Are you going to be in the clinic 3 times a week and for 2 hours a day? You need to look all these costs to the patient and say, what is it worth to me? Can I paint the picture and determine? Because you're also then going to balance it against the benefits. So benefits. Is it going to give me another year, months? It's just going to give me weeks? What is this treatment going to do for me, potentially? How is it going to affect my quality of life? Is it going to give me better pain or symptom control, or is it going to create more side effects for me? Is it going to give me improved energy and function, or is it going to exhaust me? Can I travel again? Match it with what the patient wants for themselves. And then it's filling in the potholes. And this is really benefit to talk with the patient and family separately, because sometimes they protect each other with what they know. And again, I've given you a handout of that you'll see at the end for those of you who are asking. for more detailed questions to be able to ask. But checking in with them because we all need to make sure we're on the same page, right? So what is your understanding about your illness? What is your understanding about the goal of treatment? What are your biggest fears or concerns? How are you being impacted financially, physically, socially? And what does a good day look like to you? Is a good day being able to get up and go somewhere, or is a good day I could get out of bed for an hour and sit at the table? So you need to have that picture also when we're looking at helping people make decisions. What are your personal goals? And tailor the treatment to attain those particular goals. Expect conflict, you know? We're all different here. When if you're going to switch from quantity of life to quality of life, there's going to be a lot of feelings about that, right? Because again, the family, the patient, everyone is on that roller coaster. Fear, grief, anger, guilt, confusion, all together, separately, all at once. You know, everyone needs to be heard and understood and listened to. But the conflict especially can come up. And so if there is conflict between family members or with healthcare providers, there's 3 magic words that you can use. Because as a medicine man I worked with once said that if you're pointing your finger at somebody, realize that there's 3 pointing back at you. And that means you're accountable to approaching this. So the 3 magic words are, help me understand. Help me understand. Help me understand why you do want this treatment. Help me understand why you're not recommending this treatment. It invites dialogue, not conflict. Not you idiot, why you're doing this, but help me understand, because then you identify if there's knowledge deficit, fears, etc., and you can be much more supportive in the process, because they are going to be looking at a lot of different barriers themselves. The family's got their own death history. They may be working on misinformation or lack of information. Whoa. Fear, financial issues. It could be that the person who's dying is the only one who has a Social Security check that the family is relying on. And if they die, then their financial ability goes down the tubes. Maybe it's unresolved issues, the inability to let go, or simply jinxing, if we talk about it, it will happen. So there's a lot of issues that by communicating, we need to identify so that we can help families kind of work through this process. And here's the bugger. They have the right to make decisions you don't like or agree with. And they have the right to change their mind. And it will drive us crazy. And I get it. I mean, I've been on the other side with friends and family and going, oh my God, I can't believe it. Because I want them to have my idea of a good treatment or a good death. And they apparently have another idea. And I think I know better. And they have that right. So support them. Help them understand, why are you making this decision? But I'll support you, whatever it is that you need to do. So we have to ask, whose journey is this? Am I being triggered by my own history, definition of a good death? And whose goals and needs am I meeting? So here's the other interesting thing, and that is about the fact that, and this is why living wills fail us, nothing becomes real until it is experienced. When we're stepping away, we're going, okay, this is what I do and do not want at the end of life. But when it's suddenly in your face, it looks totally different. Illness is dynamic and transformative process. It says, I've seen it before, he's changing into a butterfly. The things that we say we would never put up with, suddenly we begin to adjust to. So I have to think of my grandmother who said, if I can't travel the world, life isn't worth living. Well, illness struck. She couldn't travel as much. Well, you know, there's a lot of places in New Mexico she enjoyed and more debility. Okay, you know, I like my neighborhood. People are coming by and visiting me. Okay, my room is really nice. People are coming visiting me here. It's okay. I can look out. I can see the bird feeder. I can see the mountains. I can really enjoy that time. And then finally, you discover that adult diapers really are pretty convenient. So the things that we never thought we'd put up with, we begin to. And that's what we have to be prepared for as we're walking people through this journey. And the person who taught me the most about this was Tom. This was my second year as a nurse, so I can let you know that because I was stupid. But Tom was a 62-year-old gentleman, newly diagnosed cancer of the prostate. He had been offered a definitive cure if he opted for surgery. However, it had a chance of rendering him impotent, and he just married his 29-year-old wife. So he said, nope, I'm in control in here, ain't gonna do it, I'll go for something else, but that's it. Now, Tom was the kind of charming guy who had a stopwatch. So when he put on the nurse's call light, he timed you, told you exactly how long it took you to get to his room. So a lot of the nurses didn't care for Tom, but I liked him. There's something about him I like. So we would sit and we'd have deep conversations. And one of those conversations, he said, you know, if this cancer comes back and gets to be a problem, that's it, I'm taking my life. Now, I'd already had suicides in my life, and I said, yeah, I understood. I'd probably inject potassium because I just learned that would stop your heart. Well, there was a comment I never forgot. Now, over the next 2 years, Tom came back to the hospital again and again and again. Each time the cancer had progressed, each time he opted for more aggressive treatment, but each time we had the exact same conversation, which was, if this cancer gets to be a problem, I'm taking those pills. Because by now, I knew he had stockpiled pills, as did his physician. Now, as the head nurse of the oncology unit, and his wife showed up and sat in the chair, and she said, Tom wants to know if you'll inject potassium. No, felony, refused, but I thought, well, that's interesting, because actually if Tom wanted to kill himself, he had the means. So I thought, you know, I've never visited a patient at home before. I was always in a hospital setting. So I visited them at their apartment. And the hospital bed he was in filled up the living room. He was on his side because now he was paralyzed from the waist down because the tumor had eaten through to his spine. He was dry heaving into a bucket. He was having painful spasms every 8 to 20 seconds as I counted. And he was incontinent of diarrhea and getting sores on his rear end. This was not a scenario I ever expected Tom to be in. And I also want to be clear, this is not a hospice scenario. This was before hospice was in Tucson. So I sat down right in front of him. That's what you do. You get eye level. And I said, look, well, Tom, it looks like you're going to let nature take its course. And that little finger came up and he goes, oh no, when this cancer gets to be a problem, I am taking those pills. He died naturally the next day. So I look at that and how people hold on, and it feels like if they feel they have a choice and they have the dignity and the care and the love, that they hold on. But you never know what somebody's course is going to be. And I love this definition coming up of transformation. Accepting life with fewer conditions. Accepting life with fewer conditions. I hope I have the grace to do that myself. But that's what I see again and again. So people may redefine the good fight. It could be that they say, you know, by God, I'm going to do every last bit of treatment I possibly can because I want to survive. I don't care if it hurts me or not, I'm going to do it. Or I'm going to continue treatment because I'm going to pay it forward with some experimental stuff for a future family. Or it may be that they say, you know what, forget it. I'm going to sit on the back porch. I'm going to call my friends over. And in between my doses of morphine, we're going to sip the margaritas and we're going to toast the sunset. So people will determine their own good fight, and it may or may not change over time. So it's a part of reframing when we're dealing with end of life. And I love this. Life is not measured by the number of breaths you take, but by the number of breaths that take your number of moments that take your breath away. So there's still work to be done at the end of life. New conversations. What do I need to live my remaining life as well? And this is where the families can come in and loved ones and help. What are my goals now? Because there's always a goal to achieve, no matter how small it is. Who and what brings me joy? And am I accessing it? What's my source of strength? And am I utilizing it? How do I still express my value? What legacy do I want to live? Where do I have meaning? How do I help bring closure to those I love? Maybe it's doing pictures, maybe it's writing letters, but there's still a lot to be done, which we as a community can help people with. So I'm going to show you a clip of a movie documentary I did 19 years ago called Living Through Dying, The Struggle for Grace. And this final family had actually documented the end part of this gentleman's life and to his death. So I do want to warn you, we will see someone who's dead on the video, but it shows how they embraced the end of life in a very, I think, very warm and healthy way. So let's go ahead and advance that and hope it works.
I met my husband July 31st, 1953, on my sister's 21st birthday party. I guess we fell in love straight away. I thought I was marrying a minister, a future minister. But once he wrote his dissertation, in a sense he was bitten by the scholarly, the research bug. He had a very violent pneumonia, and he thought, and we thought, that he would die at that point. And I think he discovered there that he was not afraid of death. And he had an enormous faith, was absolutely sure the best is still to come. We both grew up in Europe during the war. Both our fathers were in concentration camps. And of course you don't know if they come back. I think for us that life is a gift and you are never sure of it. But I think when he heard that that the melanoma had come back, and when Dr. Hirsch told him that it was incurable, he had very little problem deciding that he didn't want any treatments. His first concern when he heard that he was terminally ill was to go to Holland and say goodbye to his sister and brother. You know, see the places where he had walked around as a child. And it was very interesting. Once he decided that this was the last stretch of his life, in a sense, he did that with the same intensity as he had lived all his life. He wrote a letter to all his friends and colleagues and put it on the internet and sent it to everybody. And he received the most wonderful letters from colleagues and friends. And one day he said to me, "You can't say it to anybody, but I enjoy this so much. I'm having the time of my life." I would hold his hand. I wouldn't hold him. He was ready to go. He always said, "I will slip from God's left hand into God's right hand." And that's what he did at night. He just slept and stopped breathing. And the grandchildren, you know, touched him and kissed him and picked flowers, decorated his face. It was a beautiful death. Exactly what he wanted. Oh yeah, we cried a lot. But it were tears for us missing him, more as for tears for him dying, because he was so at peace with it. Yeah, the best is still to come.
While the experience of facing dying can bring up fears and uncertainties, it can also be a time of discovering personal strengths and exploring life's meaning. No matter what feelings arise, it is a time of tremendous learning about ourselves and each other. As we accompany others on this final journey, we too are provided with opportunities to witness the transformation from suffering to understanding, from anger to grace. It is a time to think about how we want to give and receive love, to remember and be remembered.
Well, it was some amazing footage of how they embrace the dying process. But again, it's valuing the end of life journey. We are all students, so be gentle with yourselves. We're all connected and realize that what we do is going to impact everybody else. And they're just not alone in this journey. There's some wonderful resources out there. What we share is our humanity in the end. I love these little puppies. So we can now open it up to any sharing or questions. So Jennifer, you can take it back.
Thank
so
you.
much.
Yeah.
Great.
We'll go ahead and give you permission to unmute yourself if you have any questions.
And David, was there anything in the chat that you want to lift up?
Yeah, I think that early on, you had mentioned in the poll, have you experienced a good death or a bad death? Were you wanting us to reflect on that just from our own perspective, or did you want to share it all, your own ideas of what that might look like?
Well, I think it's recognizing that we all have our own perception of what a good death or a bad death is, because I've seen deaths I thought were good that the patient family thought were horrible, and the reverse. So it's just the awareness for yourself. What are my experiences? And based on my experiences, how does that impact how I work with others who are possibly facing the end of life too? So it's just a reflective time, really.
Thank you. Would anyone like to share any thoughts or reflections or maybe questions for Tani? I know, oh, please, Bonnie.
Yeah.
I have a question. How do we teach our physicians at hospitals to do a better job of letting the family know when it's time to call hospice in? I had a recent experience personally, and over and over I asked the question, is now the time? And it was never answered. And the frustration grew so much because they weren't helping. As you mentioned, you're never given enough medication. You're given a certain amount of medication in the hospital. And so luckily I work at hospice and called our hospice team and was helped out that way. But there are so many other people in the same situation who are just blindsided at the end because there's really no transparency of when the right time is, or at least some inkling of it.
Right. And it sounds like you did exactly what you needed. Are you a nurse?
No, but I work at CASA.
Okay, got it. You stepped forward and you advocated for them, and that's what you need to do. Sometimes we can't sit by and wait for the physicians to take the reins because of a variety of circumstances or their own ideas of what needs to happen, because it's the family's right to know what the options are. So sometimes I just approach them of, tell me what you understand about your disease, tell me what you understand about the goals, what are your fears? And that leads into, do you want to know what to expect? Where do you need to be? What's important to you now? And then you can take that information back to the physician and say, look, the family knows that they're dying. They want to be home in hospice. Can we go ahead and get an order for that? So, but you stepped up and advocated and got somebody in. And it's sad. It should be that difficult. There are more classes for physicians for educating them about this, but I think the challenge is that people are on and off of service so quickly, and hospitalists, I think that connection may not be there for some people. I don't know. And since I'm not doing it anymore, I don't really have a fair answer. Maybe somebody has a better answer than that, but thank you for stepping up for them.
Susan, did you have something you wanted to say?
Yeah, I actually had a very similar situation with my mom who was in skilled nursing. I saw she'd been there for 2 years at that point, and I saw changes in her that the staff was not changing. It was an excellent facility, but they weren't seeing the changes that I was seeing, spending time with her every day. And so I called work because I also work at CASA, had been a nurse at CASA, now I'm a chaplain at CASA. And I got pushback from the caregivers, from the nurses, and from her nurse practitioner. The only person who agreed with me was the woman who worked in activities, because she is somebody who sat with my mom and saw her inability to do certain activities and certain things. And it was just nice to have one person, and it was the person who actually spent time with her. And then also, mentioning the D word. So my mom was on hospice for a little over 2 months. And about 3 weeks before she died, I saw a change in her when I went in to see her. And I asked her how she was doing. And she said she was barely holding on. And so we talked about that. And every day, she had dementia in addition to other things, but every day, honey, what's happening? What's going on? And I kept saying, you're slowing down. Your body's slowing down. I could not. And I work in a hospice, and I could not say that she was dying. And when I finally did, she was in and out of consciousness by that time. And she woke up after I said that. And every time I said she was slowing down, yeah. And so I just said, Ma, you're dying. Yeah. She fell asleep, woke up, looked around the room and said, there's so much space. And she died within 36 hours. And that was the last thing I heard her say, because I finally gave her the permission to know that, I basically let her know that I knew what was going on and that I was okay with it. So yeah, it's very important. And if it doesn't come from healthcare providers, we as family members, also, as hard as it is, have that responsibility as well.
You did a great job with your mom.
Thank you. It was rough, but
But
I did what I could, so.
Thank you, Susan. Phyllis put a question in the chat. Is palliative care always for progressive to terminal disease?
no, we very often, you hear that a lot, hospice and palliative care, kind of, you get the association, but palliative care basically means comfort care. So if I have a knee replacement, I want palliative care because I want my meds so I can be comfortable. So, but when you're dealing with end stage illness, palliative care really is trying to focus on the comfort and quality of life of somebody. So yeah, it exists everywhere, but by conversation, we very often associate it with end stage, just because that's what we've done. And so many hospices are giving their names hospice and palliative care. So they don't have to talk about hospice. So it's kind of an interesting little name changing.
Yeah, but it's a very good point, is that, any type of serious illness, even without a terminal prognosis or diagnosis, you can avail yourself of palliative care. And so, yeah, it's a great point that it's not just about the end stage for palliative care, but hospice does provide that kind of comfort as well. And people oftentimes will use the word palliative care within that context. Right. So it's both and. Yeah.
David.
Please, Alan.
Again, when that question comes up about palliative care, hospice and palliative care, we use the two words very closely to each other and never really separate them and make definitions. But really, palliation starts at birth. If you're a child and you fall off the curb and you skin your knee, we're not really going to get into curative care. We're going to treat your symptoms and let the old tincture of time work its magic and you will get better by the body's own ability to heal itself. So palliation is just making the patient comfortable at that point in time, maybe not going in with the child and doing aggressive care because we know they'll get better on their own. Whereas an adult with serious disease, we get more into the curative care side. And when we can no longer do that, then we look at other things to do, such as going to hospice and saying, maybe we can't do this anymore, and maybe our treatment becomes worse than the problem that we're facing right now. Mm-hmm. So you sort of separate the two, and there's a transition, but there's some good slides that actually show two inverse triangles showing from birth, you palliate, and as somebody gets older and more chronically ill, they move into the possibility of being in hospice care and eventually succumbing to their disease and dying as a natural process.
Thank you, Alan. And someone asked in the chat, is there a way to get a copy of the recording? And Jennifer said, yeah, we will make one available of this whole session, but then also of the video that we weren't able to see tonight. You'll also have a copy of that, or a way of viewing that anyways. So, you know, recently I was speaking to some nursing students who were about to begin their hospice rotation, and they were sharing experiences they had in the emergency department or ICU setting about a crisis, you know, in terms of, you know, how do we have conversations with families during the crisis around if we should you know, use CPR or intubate, and we talked about how these conversations need to happen way upstream from that crisis point. And that when you're just responding as medical personnel in that crisis, all you can do is do the best you can to treat what's in front of you at that time. But do you have recommendations for us about how to begin maybe having some of these conversations before a crisis happens with our family? How do we enter into some of these conversations?
I just jump right in. I mean, I started having the conversation with my kids when they were 18, and they hated them. Like, Mom, why are you talking about this? Or are you going to, you know, is there something you're not telling us? You know, now they're all in their 40s, and they just like, oh, you're going to talk about end of life. How much money are we going to get when you die again? I mean, become comfortable with it. But I've made it a part of our life journey of what do you want? How do you want it? But especially when somebody's being diagnosed with any kind of illness, now's the time to offer, you know, talk about what are the limits of your wishes or not. And that's where that serious illness conversation comes in, because that should be used very early in the conversation so that you can keep checking in with it again and again over time, because their answers may change over time. The answers will change over time. What we want to do is avoid treatment by default, which means if they don't tell us what to do, you know that we're going to go gangbusters, whether it's appropriate or not, mainly because of fear of litigation or fear like someone will say we're not doing enough. So if people don't want to have the conversation, I'd say, well, then that means you might be subject to all kinds of things that you don't otherwise want. Or I can just say, in my case, this is what I would want. And I'm wondering how you feel if it was your case too. So put it on yourself and get them thinking, because you may not get an answer right away, but like for the night's presentation, just get people thinking and pondering so that when they start coming across it in real life, they think, oh, I think we've mentioned this before. There might be a resource or someone to talk to. But yeah, it just should be an ongoing, you know, after dinner, after Thanksgiving conversation when nobody can move because they're too stuffed, that kind of thing is, you know.
That's
what
great.
are your
Is it helpful to utilize tools like 5 wishes to enter into these conversations with folks? Have you found that advanced directives?
I'm not so you know, anything in documentation is good, so I won't negate any of that, but just recognize that again, when the reality comes, things look very different. And sometimes like 5 wishes, that looks kind of really simple about what do I want. I want to be comfortable. I want music. It's like, well, that's a no-brainer. Really, the bigger conversations are the extent of the illness and incapacity that you're dealing with, et cetera. So again, I think that's where the serious illness conversation comes in, to get people thinking and talking. Or when you see about more deaths from friends, family in the news, talk about it. Wow, this is what happened to that person. What did you think? You know, how would you, if this happened to you, what would you want to have happen? I mean, that's a real definite application that you can apply later on, that you've had a conversation. So yeah, use what's around you.
I think that's really good. It's helpful advice. And I feel so strongly that when we're not able to have conversations around end of life, or the fact that we will die, each person will at some point, that it also pushes our grief into the shadows. When we can't talk about death as if something that's going to be in the future, it makes it difficult to talk about the reality that we live in. And when we aren't able to say goodbye to loved ones, and then as we struggle to live with the reality of their death, we lose a language to be able to talk about these things as well. It affects us not only leading up to the death, but afterwards as well.
Right, right. Well, Dr. Biox says there's 5 things you need to do before you die, is to say, I love you, I forgive you, will you forgive me, thank you, and goodbye. But the first 4 things we could be doing right now, and I really encourage people to do that. Write letters to your family members, tell them why you love them, tell them what you learned from them. Have that in documentation now and ongoing. Actually, I write a letter to my sons every year for that. Just so you have that in writing and there's nothing left unsaid. That's what's painful, is the unsaid. I wasn't ready, I never told them.
That's great. And then in the chat, my estate plan attorney had a questionnaire she provided me to share with people I was considering naming as my agent as an MPOA, to make sure that they would understand my wishes and they would be able to fulfill those wishes when the time came. It was very effective starting the discussion. So it's, yeah, there are tools out there. There's ways of thinking about it. But I agree that it is always more complex. But it's practice. It's kind of like what Tani said at the beginning. We just need to practice entering into this, and we get better as we go along. Deborah, did you have something that you wanted to say?
Thanks, David. Yes, I did. It was at the very beginning of your talk, Tani, which I totally enjoyed. You talked about this as the unpredictable journey. And what I wanted you to say too, but also a transformative one. Because that's exactly what you're saying. The more we can talk about it, the more we can embrace it, the more we can live it, the better.
Right.
So I'd like to add that to the unpredictable nature of the journey. I mean, that's what makes it special.
That fits. Absolutely.
Thank you. Thank you.
And I love your definition of transformation, accepting life with fewer conditions. Huh? That's a
I
beautiful.
can't take ownership for that, but I don't remember where it came from. I don't know if that was Tuesdays with Maury or whatever, but I loved it.
I don't know, but we're just going to attribute it to you from now on.
Hey, David or Tani, are one of you going to talk about next month, sort of how it follows on to tonight, maybe? Just to pique people's interest?
Yeah, Tani, please.
So I had mentioned that I think people understanding disease progression and the dying process is absolutely critical for how they enter into those phases. And so I go into how the body shuts down to die, what we can do, the very simple language that we can do, because we really want to take away the fear. And we want people to know, because they feel so much better when they understand. So not only are we going to talk about the wisdom of the body, but we're also going to talk about the mystery and the visions, as one of our participants talked about earlier. The closures, there's an amazing time. It's an amazing sacred time that we can learn and actually feel better about. So that's the whole point, is let's get into the nitty-gritty.
So please, everybody come back on October 19th. If you haven't registered, please do. It's very simple. And once you register, then you'll have, we'll be able to send you some more information, and then we'll be able to tell you how to access the recordings after the session's done.
And Jen, I know Tawny referenced handouts. Are we gonna send all of that out at once with the video, or what are your thoughts about that? Just so people have an expectation of timeline.
Yeah, so I will email those out to you hopefully tomorrow, for sure Monday. But we'll also go ahead and attach them to the registration page so you can go and download them as well. So once the video's up, they'll be up on the registration page as well. Okay. So before everyone heads out and we wrap up, your feedback means so much to us. We've already begun planning our 2024 series. So it's the feedback that you provide that really helps to tell us what's working well, what's not working well, things that you want to see from us, talk about. So we're going to try a new, since you're all expert at polls now, we're going to try a new system, if you don't mind. I'm going to launch a poll. There are 10 questions. They're relatively short, but if you could take a few moments to do that while we talk about what's coming up, I would appreciate it. And so you'll just want to make sure to answer all 10 before you hit that submit button. Okay. All right. And while you're all doing that, don't forget to register for next month's session, and then David will talk a little bit more about what's coming up in November.
Hospice month in November.
Say that again.
Hospice month is November. So
It is. You know, there are so many things going on that every month is National Many Month thing. And it's also Caregiver Month as well. So we're very excited to be able to share information about what it is to be a caregiver, support, services, how to know when it's gotten too much for you and maybe some additional support is needed. But on November 16th, we will be able to enter into this important conversation. I highly encourage you to come, whether you've been the recipient as a care receiver, or you've been a caregiver, or you can see yourself in that role at some point, that it is vital information to have. So many of us are caregivers, and oftentimes we do not know that we are a caregiver or don't identify ourselves that way when we are. And the support that's out there is invaluable for us to be able to have that care for ourselves as we're caring for others. And as so many of you make donations in support of this education series, we encourage you, if you have the opportunity, if you are able to make a small donation, it makes a tremendous difference. It means that we're able to continue to provide this free of charge for everyone in the community. And it was exciting. We have lots of folks from here in Southern Arizona and different parts of Arizona, but then in states across the country as well. And I think somebody from Canada as well is here with us tonight. So it's a large community that we're gathering together for these conversations, and your donations make that possible. So thank you so much for the support.
And just to highlight a few, you can make donations on our website, but we also have some fun now that fall's coming and the holidays are coming. You can support us in a number of different ways just by shopping online. We recently created a ShopRaise account. So there are about 1,000 retailers who are part of that app. And so every purchase you make, a portion comes back to Roots and Roads. We are also part of Walmart's Spark Good. So if you shop online at Walmart, your purchases can help the foundation as well. And then we are part of Fry's VIP Rewards. So if you're a Fry shopper, link us to that and we'll get, funds from when you shop for groceries for your family. So
Fantastic. Well, I think that's it for this evening. Tani, thank you so much. If you haven't already read in the chat, a lot of kudos from folks. It was a great session tonight, and we're really looking forward to next month, and hope to see you all back here. And again, I know Beth put in the chat about the time, and that, you know, it's not a convenient time for everyone, but that's part of why we do videotape these and make them accessible. So if you know someone that you think might be interested, as Jen said, it normally takes us about a week to edit and kind of get it up there, but you can always direct them to our homepage, and it should be up there in about a week, along with the handouts and that video clip that we didn't get to see tonight. So thank you. Do 5 minutes? Yes, yes. Thanks so much, everybody. Hope you all have a great night, and we'll look forward to seeing you next time.